It's just a huge honor for me today to be podcast interviewing Dr. Irfan Atcha, DDS, DICOI, which is a diplomat in the International Congress of Oral Implantology. He's with NewTeethChicago.com, and my gosh, he is amazing. Dr. Irfan Atcha graduated in 1996 from UIC College of Dentistry. What's UIC? University of Illinois?
University of Illinois, Chicago, correct.
Chicago. Dr. Atcha has been in private practice in Chicago, Illinois since 1996. He is licensed to practice in Illinois, Florida, and California. His practice is focused on dental implants, bone grafting, cosmetic dentistry, and sedation dentistry. He has performed over 1,000 arches surgically and prosthetically of all on 4, 5, 6 teeth in a day, Teeth Express, full arch dental implant cases. He is trained and certified to perform IV sedation of the ultra-high fear patients for their comfort. Dr. Atcha has conducted lectures and hands-on courses for Noble Biocare, Noble BioHorizons in 2009, 10, 11, 12, 14, and 15. He is a diplomat of the International Congress of Oral Implantologists and has been awarded first place for a table clinic award at the ICOI for the immediately loading of zygoma implants. He has published several articles on full arch all-in-4 dental implant concept with guided and skilled approach. Dr. Atcha is a member of the ADA, Illinois State Dental Society, Chicago Dental Society, ICOI, and American Society of Dental Anesthesiology. He and his wife love to travel, spend time with family and fitness. My gosh, I love your YouTube videos. I mean, you sit there and interview patients afterwards, and I mean, they're just hitting every buzzword. I was 98 pounds, and I'd gotten down to 81 pounds because I couldn't eat, and now I got back to my normal weight. I was afraid. I mean, you watch those YouTube videos of some consumer anywhere really in the United States because with websites like yours, I bet you get people flying in from all over the country.
We do. Actually, we do draw people from, I've had drawn people from Minnesota, from Ohio, from Wisconsin, and even as far as Florida. So we do get people from different parts of the country.
And it's weird because we both have our diplomat in the International Congress of Oral Implantology, and so many times you meet so many amazing implantologists, and then you go to their website and it just says dental implants, and then you go to your website and there's video testimony and one lady said she saw you on TV. So you're doing television advertising.
I've done some television advertising in the past on local Chicago news channels. So, and then it's all about creating awareness and letting people know what you can do to help them. That's the biggest thing when it comes to what we do for patients that have missing teeth or are about to lose their teeth. It's a big need that we're trying to fulfill in the dental community.
So I really love it when there was a man on there about my age who said, every time I look in the mirror and smile, it was worth it. And another lady said, it was costly, but now I can eat, and now I'm not afraid of getting my pictures taken. And I mean, you just must feel, you're just changing people's lives on a daily basis.
Absolutely. I mean, it's pretty much, dentistry is a great profession. And, as you know, I've been a big follower of you on Dentaltown and your MBA courses. So, it's been a good eye opener. Basically we're transforming lives. People come in with self-esteem issues. People come in with broken teeth, missing teeth, and they want to know what you can do what we can do to help them. And really, when you really take care of somebody at that level, they really appreciate it. They really appreciate the fact that they can eat with their spouse. A lot of them, their husband have never seen them without teeth. They're wearing dentures. So it's a very private thing for the patients, and it's something that they really reconnecting them to something that they have lost or that they're about to lose. So it's really changing and, as you said, transforming lives.
I've had a patient a decade. I practiced 30 years. About one lady a decade will say to me that when she got her dentures, she couldn't sleep with them in at night, and she couldn't take them out in front of her husband. So she kicked her husband out of her bedroom and locked herself in there, and he was sleeping on the couch. And after a year or two, he, went away, and she basically equates losing her teeth to losing the love of their life, and they cried. I mean, it's a very big self-esteem deal. I've given every denture patient, and I like that in a testimony that another one of your testimonies said where when it was all over, he gave me his personal cell phone number. And I know with women dentures, I always give them my card. I always tell them this is my cell phone number. I said, if you ever get in a cosmetic emergency, this thing breaks, whatever. And one lady called me, and it was actually on a Thanksgiving evening, and she went in the bathroom to clean her dentures, and she dropped in the sink and busted. And she called me
Oh,
hysterical. And I said, well, we're both in Awatuki. I said, just cover your mouth, run to your car, and I bet I'll beat you to the office. And I hung up. And I
oh,
jumped in my car and I drove straight down there and I unlocked the front door and left it open and went in there and started getting my stuff. And she came in, she was crying. But I mean, it's um, mental health is more important than oral health. And a lot of
right.
these oral rehabs are not fixing their oral rehab; they're repairing their mental health.
Absolutely. Absolutely. I mean, that's, you know, when you give somebody, if they know they can get a hold of the doctor, it's a very personalized and individualized care. You know, each patient you become near and dear to. You get to know their family members. You get to know their other loved ones. And you know, a patient wants to know that after the amount of time that they've spent with, you know, with a clinician, and you know, the time involved, the investment involved, you know, they want to know that they can access the doctor. And so, you know, we're available. We also have 24/7 emergency service, our office call center that they can get a hold of me or my associate if we need to. But I do, but the patients do get my cell number because I want to make sure that if there's sometimes they may have a question if we do surgery on a Friday over the weekend. If they have any questions or concern, they can reach out to me.
Okay, well, you're I wouldn't call you that top 1%. You got to be that top 0.0001%. I mean, 1,000 arches. I mean that's. I mean, there's not 100 people who have done 1,000 arches. So walk these kids through the journey. Podcasters tend to be younger. You just had 6,000 kids walk out of dental school and they graduated and they think they learned everything and they're going to realize that they just left kindergarten class and they're going to start their journey across the street. How do you go from I graduated from dental school, I never placed one implant, to
Sure.
being what you've accomplished? How does that journey work? How did it work for you?
Well, so I've been practicing since '96. For the first 10 years, I did a lot of, like, you know, I did the LVI, a lot of cosmetic dentistry. I've done some Dawson courses, you know, so I did a lot of restorative dentistry, you know, and then I realized I had family members like my grandparents. They had dentures, you know, I've made dentures for them, one set, two set, you know, and then they realized that there's something that they were not happy with. They couldn't do anything. And back then, when I first graduated, I wasn't doing implants. I was just restoring them. Then I started learning about dental implants. I started taking continuum. I started taking residency. I started taking courses to really help patients that are missing teeth. And you know, by even simple thing like, you know, we can take our denture patients, put two implants in the lower jaw, and make a denture that snaps on. That is a big thing for a patient, so that it doesn't slip and slide. You know, yet alone the full arch rehabilitation with all on 4, 5, and 6. So it started with just taking some advanced courses. After taking advanced courses, doing some, you know, the mini residencies. After doing mini residency, getting a fellowship in the ICOI. After the fellowship, I wanted to do the diploma, and I wanted to, you know, just go all out. And then just, you know, seeking out individual high level courses and or hands-on that suited what I wanted to do. And I wanted to do full arch when I saw my family members suffering through you know, what they went through with their dentures.
So in America and around the world, so much of the courses are tied into the manufacturers. And a lot of
Hmm.
the young kids ask on Dentaltown, they almost feel like they need to pick the system before they sign up for the course because
Yeah.
all the courses are tied to a system. What would you
Right.
say to that young kid on that journey? Do they need to pick a system first or a residency first? Or how do you make sense when you can go to the ADA convention and see 175 different dental implants for sale?
That is so true. I mean, I would advise them not to pick the system. I would advise them to learn from the leaders. There are lots of leaders out there that are conducting residencies, continuums. Learn the basics. Learn everything about implantology from zero, from A through Z. You can experiment different systems. I mean, there are, just like you said, 175 different systems. I've gone through at least 4 or 5 different ones, narrowed it down to 2 that works in my practice. So there's no right or wrong about which system works. Is what do you want to do? What do you want to accomplish? Do you want to do single teeth? Do you want to do multiple teeth? Do you want to do implant bridges? You want to do overdentures? You want to do full reconstruction? But don't pick the system. You cannot go and learn having implants over the weekend and then come back on Monday morning and start placing implants. No, you go through a proper continuum. You have you have people that have had years and years and decades of experience on teaching these courses. Take that, and from there, that's a good starting point. Then you can spin off on however way you want it. Then you can go to a manufacturer course and see, hey, what do I like about this system, or what do I like about it? It's never really about the system. I mean, we use the best systems out there, but patients don't know what systems I'm using. I know I'm using a good system because for what I need to do. But for a young dentist graduating, go pick a mentor, pick people that have conducted residencies, people that have conducted continuums, and go with that first. That's a good starting point.
Well, do these analogies hold true? It wouldn't matter which clubs Tiger Woods was using; he would beat you and me in golf.
You know, there are so many different implant systems out there. Yes, I mean, you got to have to use the one that has the clinical research, the background, the material science behind it. Do you like the tie-unite surface? Do you like the laser lock surface? What does it do for your patients? I mean, you kind of have to do a little research and background yourself. If the implant company doesn't have a lot of research and development behind it, I'm sure it works. Titanium integrates. I mean, all titanium integrates. But what are you trying to do? Are you trying to immediate load? Are you trying to delay load? So you kind of have to do your research before you pick a system.
So a lot of them are hearing mixed reviews about implant hands-on courses because there's advantages if you go to non-U.S. countries where they don't have lawyers and you can go place a bunch of implants in Mexico or Dominican Republic, but then you don't get to see the follow-up. You don't get to see that person, 3 months later, a year later, or whatever. You've recommended they do many residencies. Do you have any that you can recommend?
Well, I mean, I know there's a couple of them in like Dominican Republic. I know Dr. Garg does
Arun Garg.
Arun Garg, he does, and from what I know, he puts on a pretty good residency. I've known people that have gone to his residency. I think it's in Dominican Republic, and I'm sure it's pretty good. I don't know if there's any hands-on here, but then again, you're right. There is no follow-through. There's no follow-up. You don't know what the patient looks like a year later or 2 years. But you gotta. I say start somewhere. I say you got to start somewhere. But one of the advantage of these hands-on courses that you're able to either place, you're able to, and I'm obviously under their certification, and you're able to get a lot of experience.
Any you recommend?
I mean, Garg is a really good one. There are a couple of, I don't know their names, but there are a couple of them out on the West Coast. I know that they also do some. I don't know offhand because I've kind of been away from the educational world. But I'm right now, the first thing that comes to my mind is Arun Garg's training.
Well, you set yourself up with this question. You said you tried 5 or 6 systems, but you're down to 2. So I know there's 1,000 kids driving to work right now listening to this podcast saying, "Well, tell us which 2. Which 2 are you down to?"
I'm down to BioHorizons as my main one, BioHorizons, and I'm also using Zimmer, so that's 2, and then third one on certain cases I'll use Noble BioCare. Those are the 3 that I've narrowed it down to.
So BioHorizons, that was started by the late Carl Misch, correct?
Correct.
Correct. Did you was that hard to see him pass for you?
It was very heartbreaking. Dr. Misch has been a good mentor. I did his courses as well, and I heard him speak, and we lost a good leader in our community. So it was, and the implant system that was developed, especially the laser lock system, it's a very good system. We've seen some great tissue regeneration around the neck of the implants, great primary stability. I use that pretty much for all my full arch cases. That's pretty much our workhorse is BioHorizon laser lock system, and they have different prosthetic components for different things that you want to do. I also use that for my single unit implant cases as well. Yeah, I mean it's a great system.
My gosh, I would give anything if you'd make an online CE course on that system on Dentaltown. These millennials, they got $350,000 in debt, and we put up 411 online CE courses, and the views are coming up on 1 million.
Oh, that's fantastic.
I know. You would be, if you ever want to write an article on that for Dentaltown magazine or do an online C course, whatever. I mean, you're an amazing man, and not only are you delivering the goods, but your business acumen is off the charts. Your website, patient testimonials, I mean, just everything. I mean, I can't find an A minus or a B plus in anything you're doing.
Well, thank you, thank you for the compliment. Appreciate that coming from you. Appreciate that.
Yeah, I mean it's world class. Again, any advice if you were giving a commencement speech? You just had 6,000 kids graduate this week, and they're throwing their hat up in the air, and they're so glad to be out of dental prison, and they're ready to start the world. And a lot of them are afraid. Like when I graduated, I had my office open in 4 months. And
Okay, well,
I just walked out and opened it up. A lot of them think they have to work at corporate, or that when you and I graduated, it was a lot easier. It was the golden era, and you and I are lucky because we were born at the right time. I doubt they'll say that at my funeral. They'll probably say I should have been born 30 years later. But is the golden era gone? What would you tell these kids? Can they walk out, open their own practice, and go for it?
that's a phenomenal topic because the golden era. It's everything is a matter of perspective, Howard. Everything is a matter of perspective. It's a business. At the end, yeah, we've assessed. We've taken courses. We went to 4-year dental school. We've gone through residencies. We've gone through fellowships. At the end of the day, it's a business. If if you want to, opening up and practice from scratch is definitely a daunting task because nobody knows about you. You need to get your marketing in place, your staff in place. Should I sign up with insurance? All that stuff. My recommendation would be first time around, buy an existing practice. That is my recommendation because from day one, you'll have cash flow. Sure, you'll pay more. Sure, you may not have all the bells and whistles, but so what? What's the most important thing in the office? Revenue, patients, right? Patients coming in. You have patients coming in. You have a hygiene department. You can generate dentistry from it. You can bring your own reality into it. Especially if a dentist is retiring, I would hands down advise to not set up a scratch practice from the beginning. And I'm not saying that nobody can take a scratch practice and take it up to $500,000 a year right away. It takes time. But buy a practice and then build upon it. Nurture it. You got to work hard. There's no substitute for hard. You got to put your sweat equity into it. Whether it's marketing, whether it's proper training of the staff, clinical staff, administrative staff, business systems, how to answer phone calls, how to do treatment planning, how to present cases, how to get case acceptance. How do you take somebody that is resistant towards dentistry and to educate them and motivate them to get it done? Those are the things that a new grad should invest in. Instead of learning about, should I buy this new gadget or should I buy this? That doesn't make you do dentistry. That doesn't do anything for you. I think that's just all shiny, and all you do is incur debt. I would say you buy a decent sized practice with good equipment, with goodwill, and with lots of patience. You'll do well because it'll pay for itself. The revenue from that practice will service the debt, and not only that, you'll have some income too as well. That's my recommendation.
Okay, I know how my homies think. I've been on Dentaltown several hours a day since 1998. A lot of them are going to listen to you and say, "Well, dude, you live in rich Chicago. I'm out here in Parsons, Kansas, and you're lucky. You were born in the right place. You were born in New York, L.A., Chicago. I'm out here in Bumblebutt, Iowa. Nobody's going to pay for a full arch of implants in the middle of Iowa." What would you say to that?
Well, that's not true because there are people that come from small towns, and my average patient comes from 30 to 40 miles away. 30 to 40 miles away is a lot of farmland around Chicago. So they're willing to drive up here and they're willing to pay. I have some colleagues that are in small towns. It's how you position yourself and it's how you present yourself. It doesn't matter where you are. It doesn't matter if you're in small town in Ohio or if you're in New York City or if you're in Chicago or Los Angeles. That's a myth. Being in a big metropolis, yeah, you have a lot more people, but you can be in a mid-sized town or small town and position yourself as the go-to person for this, and you can do it and charge the fee that you want to charge. And people have to find value. People have to exchange value. If they find value in what you do, you're the person because you have the track record, you have the patience, you can back yourself up. They'll come to you. They'll come to you from everywhere, and they're willing to pay for your fees. So it doesn't really matter if you're in a smaller town or if you're in a big metropolis. In a big metropolis, yeah, you have a lot more people have a lot more dentists to choose from. But again, it doesn't really matter if people don't know about you, whether you're in a big city or if you're in a small town. They'll never come to you. They got to know about you.
When I was walked out of dental school, only rich people flew in airplanes, and they were usually being paid by the Fortune 500. And back in the day, it was Eastern and TWA and Braniff and on all these expensive deals. But Southwest Airlines is now the number one carrier at 27% of all seat miles flown. And
Wow.
I can't tell you how many dentists I've talked to that developed elaborate websites like yours with patient testimonials and all that stuff. And people just jump on an airplane and they fly to that office because they don't have the faith and the trust that the dentist in their small town can do these skills. So,
Right.
not only are you a great chef, you got a great restaurant website. I mean, you're making the food and you're getting the information out there. A lot of people might be wondering, around the country, they're like, well, is there not a clear choice in your area? I mean, did big corporate come in there and did that hurt you, or how many clear choices are around Chicago area?
Chicago's got a clear choice. Chicago has a clear choice, been around for the last 7, 8, 9 years. And they've created a lot of marketing campaigns, so a lot of more people are aware of what the full arch construction, all on four, teeth in a day, all that's available. So yes, I mean they've done a great job of creating awareness. Look, I look at it this way: it doesn't matter if you have one clear choice or two clear choices. Everybody is different. Everybody has a different position. You position yourself differently. I'm sure Clear Choice does a phenomenal job in delivering their services. We do a phenomenal job in delivering our services. With us, everything is in one office. I'm the doctor who does the procedure, and I'm also do the follow up. And people want that one-on-one connection with their doctor. So it really didn't do anything to our business. Our message in marketing and our message in getting the word out has always been consistent. I'm sure Clear Choice is very busy with what they do, and we're busy with what we do. And if there's enough patients to go around for everybody. I mean, that's the way I look at it.
I always look at Clear Choice as, when John F. Kennedy would always say, "A rising tide lifts all boats,"
Sure.
and I can't tell you how much these dentists in Phoenix that advertise on TV about Lanap or Clear Choice or any of these deals, then your patients are coming in and saying, "Well, I saw on TV this, they're getting information. Doesn't matter if it's you, Wikipedia, or Facebook or TV, but they're coming
Yeah.
into the one they trust."
Right. Absolutely. So who are people going to trust, Howard? People are going to trust who they see the most. If your message is consistent, whether it's internet, social media, your email blast to the patients, whatever it is, if your message is consistent and you're consistent and persistent on your message, people are that your brand becomes more aware. They see you on whether it's your Facebook page or whether it's a YouTube. They see you more and more and more. They see you more and more. Trust. Everything about what we do is trust. And you don't need years and years to create trust. You can create trust in instant. It's all about creating the expert status in what you do, and also getting your other patients to say, I went here. This is what they've done for me. This is my life has changed, and it takes all the uncertainty out of the equation when patients have already can see what your other patients have done. You got to start from somewhere, and again, I keep saying that there are enough patients in every metropolis anywhere to go around for everybody. You just have to. People will trust you. People will come to you if they see your message consistently over and over again.
That's a great message because in some of your YouTube testimonials, a lady said, I wouldn't have done this if I didn't trust you, if it wouldn't have been you, and that you were a big part of her deciding to get over the fear and the cost and get it done. And I
Right.
look at the physicians. There's 211,000 dentists, there's over 1 million MDs, and they work trust so much more. I mean, Mayo Clinic, Cleveland, Sloan, Scripps. I mean, because they know if you go to the store and you want to buy a bottle of water, that any American knows this is a
Yeah.
bottled water. But when
Right.
someone says, well, you got cancer and we got to cut off, we got to do surgery on you, it's like, well, how do you know if that's, you hear people just in your own personal life say, well, if someone told me I had to get this cancer treatment, I think I'd get 3 opinions. Well, they don't get 3 opinions when they go to the Cleveland Clinic or the Mayo Clinic. They walk in the Mayo Clinic and they have trust. And
Sure.
the whole deal in dentistry, when you tell someone they have 4 cavities, they're just looking at you like, you might as well say you need to have your transmission redone. You might as well, I mean, there's just a lot of things invisible to a
Right.
lot of people's experience. I mean, when the plumber comes to my house and says I need a whole new toilet, or the dishwasher repairman says I can fix it, or you need a whole new dishwasher, it all comes down to trust. How would I know if the dishwasher could be fixed?
Right.
I've never even used the thing. So the bottom line is, I just think you just have an aura of trust. Like when I talk to you, when I see you on your videos, I mean, you just really got trust. By the way, my homies are driving, and so what I do is I retweet my guest's last Twitter, so they can go to my Twitter at HardFriend. My last retweet was you at Implants Chicago, Implants Chicago. So
Right.
I just retweeted that, and it's amazing. One of them is use of bone reduction guide in all-on-4 dental implant surgery, a concept misunderstood by the masses. And oh my God, is that the actual blood and guts gory detail? I mean, that is you could call that a dental war. And then another one, a classic moment with you, bring the family, your patients, to see the new teeth afterwards. And
Yes.
I mean, you're just hitting all the buttons. I mean, you got people verklempt, you got people crying. It's a husband, his wife's all excited. I mean, God dang, dude, you just nail it. You should have gone into marketing. What made you go into dentistry instead of marketing? You should have an advertising firm in Manhattan right now. But really, you're just crushing it.
Thank you. No, so I aside from what I love to do with dentistry and changing lives, I'm a student of marketing. I am. I like to study marketing. Now, what is marketing? Marketing is something that you need to let your audience know about your product, services, and solution. If your audience, your target audience, know about your product and services and solution, if you have inner conviction about your product, service, and solution, why wouldn't you want to let that message be aware to others? That's been my thing, and I think that's been kind of like, that's not something that you learn in dental school or during CE courses. That's something that you innate have to have it. You build so. You worked so hard in dental school. You've had so much in spent so much in dental education. You went out and you did all this advanced courses and residencies and education. You invested in a dental practice. Well, why wouldn't you want to let your patients know, or the public, or the community, or the world know? I mean, if you look at that's why social media is so good, because your pool is the worldwide. I mean, there's 7 billion people you're attracting. You're not just attracting to 1,000 or 2,000 or 3,000 people in your town, or 20,000 people in your town. So marketing is very important. Marketing and promotion of what you do is very important, not only from your aspect, but what other people are saying about you.
What would you tell a young kid who just spent 8 years learning math, calculus, physics, geometry, and the Krebs cycle, and will never use any of it the rest of their life? Yet they'll open up their dental office and they won't know how to use QuickBooks Online. They won't know how to do payroll. And they sure as hell won't know how to do marketing. What would you tell a young kid what would be your short list of how to learn how to market?
I would say, just look at different businesses, how they promote. It could be other dental offices, or it could be some other businesses that's very successful. If there are successful businesses that are growing, that are profitable, that have the message out, just look at them and learn a few things from them. I don't know. What do the telephone company like Verizon or T-Mobile, what are they using? How are they marketing themselves? How are other industry, other verticals, whether it's in healthcare or non-healthcare, how are they marketing? Look at their marketing strategies and see if you can make it real to your practice. Every practice is different. Some people just want to go for the veneers. Some people want to go for, the PPOs. And if you belong to an office that you have to sign up a PPO, great. That's great. I did that for the first I would say first 8-9 years of my career. The insurance company markets for you. People come in droves, and it's a different type of a dentistry, and it's good. Now my model is a little different. Mine's more about awareness, it's more about education, it's more about branding what I do and what myself and what the office is about. So definitely learning different marketing strategies and promotion to get your practice from somebody who doesn't know about you to even doing postcards in your backyard. Even creating like a Twitter handle and then just tweeting it, or outsourcing the tweeting to your staff. So make sure they constantly keep the feed alive, so people are connected to you. People have to be connected. People have to be connected to you, online and offline, and that's how they'll remember you. They'll know about you.
I look. So you don't take any PPOs?
I take certain PPOs, and my associate takes that. Like there's only 3 PPOs that we take, but the rest of them we don't. We only take 3 of them, and on a very limited basis.
And on your marketing, do you still do any old school direct mail, or is it all digital like Facebook ads, Google ads?
A little bit of both. I think you have to hit both. You have to hit online and you have to hit offline too. So, and you have to hit some targeted zip codes with mailers, and you can do some postcards for new residents. So I do a little bit of both. I think it kind of balances out. But a lot more people are online now. A lot more people are with pay-per-clicks, with Facebook ads, sponsored ad. I think that seems to be where people are glued to nowadays. Everybody lives in a virtual world, so everybody's on their phone or their iPad or iPhones or Galaxy, and this is how they find you. Especially if they're looking for high-end services, they're going to Google the services. But there are still a group of people that'll still pick up a Sunday newspaper and may respond to your ad, or may respond to you postcard you send. So it's both. It's a little bit of both, but it's more going towards digital. That's for sure.
It was weird because our whole childhood, Americans were studying at 4 hours a day on television. Right. And then when the smartphone come out, the 25 and under basically fell off the television screen completely. And they actually fired Jay Leno and replaced him with that new kid, what's his name, Jimmy Fallon, because because they were trying to get the young kids to come back to TV, but they're gone. Basically, television's over 50 now. But what I find interesting is that for all my life, Americans held steady at 4 hours a day television time, and now they've switched it to screen time, and it's 5 hours. Wow. So it must be much more engaging, because what was the complaint of our whole childhood? You had 3 channels, ABC, NBC, CBS, and there was nothing on. And then cable came out, and it was weird because now you had 1,000 channels. And what was the complaint? There was still nothing on. But now when you have a smartphone, you have 300 million websites.
It's incredible.
And with 300 million websites, they've upped their screen time 20%. I want to go to treatment plan presentation.
Sure.
When you go into the general dentist, the biggest offices, the top 10%, all have someone who presents the treatment and the finance. Mm-hmm. But when you go into orthodontist office, they're like 95% of orthodontists after 2 years out have a treatment plan presenter, financial coordinator. Some dentists think that the doctor is a doctor. You're the one doing the surgery. You should present the treatment. Do you present the treatment, or do you have a treatment plan presenter, or do you present the treatment and then you have a financial coordinator do the finance, or how do you divvy up those skills?
So it's another great topic to discuss. So when I am with a patient after the evaluation examination, if I have time, I present the same day. If I don't have time, they come back. I do everything. I present everything to the patient, from going over the clinical part of it, going over the steps, and I also present the fees. I present the fees. I feel like if they fees and how the sequence of treatment, the steps that comes from me, it just has a higher impact, because at that time, some patients may have objections, some patients may have a lot of questions that I'm, I guess, well versed to discuss and handle any objections. Once they're committed, once they say yes, Dr. Atcha, we want to move forward. I want to go ahead. Then I get my treatment coordinator. Then the details of how it's going to be, financed, paid, or whatever, it's worked out with them. But I'm there until the patient is saying, yes, I want to move forward, or I want to think about it, or I want to go home. I need to discuss with certain things with my staff, with my spouse. Then we have a second or third consultations scheduled for them. But I do all of it. I present it. I like to present fees. And case presentation is not about case, but it's about listening. It's more about what the patient wants, not about what I want. It's about what they're telling me, what their personality is. Are they bottom line? Are they very direct? Are they somebody that take very slowly? I want to make sure that when I present my treatment, I try not to use a lot of dental jargons. I try to use words that they can comprehend, and I try to keep it very simple and see how it's gonna change their life and how it's gonna impact them. I try to make it very simple, and I try to make my treatment presentation no more than 15 to 20 minutes. Because if you're doing more than that, then the patient gets confused and they walk out and do nothing. But when it comes to fees, I'll go over the fees, but then I'll have my staff go over exactly different payment options and so forth, and then we schedule for whatever the next phase is.
Every amazing treatment plan presenter I've ever met in my life has always told me, if the doctor states the fees before he calls me in, and the doctor owns it and says it, it just gets rid of the issue so much. And every treatment plan, some of them might have worked for one office for 7 years, when working another, they'll always tell you that when the doctor states the fee with confidence, that helps them close the deal so much.
Absolutely.
A lot of times a patient will come in and need a bridge or a case or this or that, and then they say, well, I'm going to go home and think about it, and I'll call you back. And so many doctors never, ever try to get them back. When people say, if 100 people, after you did your whole presentation, everything, they said, well, I'm going to go home and think about it. And they don't call back. They don't come back. Do you follow up on those leads to try to get them again, or not?
Well, so let me think about it. Let me dissect that a little bit. When see people, we are presenting, we are selling. I mean, I'm going to use a word. A lot of doctors don't like to use a word. Our services and our solution. Whether it's hygiene, whether it's recall, whether it's full mouth all-on-4 reconstruction veneers, it's our services that changes their life. If we are not if a patient says, let me think about it, that means either the patient didn't understood, there's a misunderstood word in your presentation, or you went too fast, too steep, and they completely zonk out, or the patient is very fearful about dentistry. Majority of people are fearful about dentistry. So I want to think about it, meaning like I need to know a little bit more. I always ask the patients, did I do my job properly explaining the treatment? And if they say yes because they want to get away, then I just say no problem. I'm glad I did. If you want to go home, think about it. By all means, go home, think about it. And it will give you all the time in the world. But if you think about it too much, your problems will worsen. And usually a week later, I'll have a staff member follow up with them. And I will tell you how many times that we ended in a very nice high note. We gave the patients a treatment plan. A week later, we did a simple phone call, maybe an email, and that patient appreciates it. That I'm glad that you actually call back. Let me come back for a second consultation or a third consultation. I had a patient today. The patient came back for the third time. She came in first time, came in, did the paperwork, had a scan taken, x-rays, boom, left. Because she was afraid. Half these people are afraid. She couldn't stay. And I'm like, can we move to the next step? Can I go over? No, I got to go. Came back. Okay. Staff followed up with them, got her back the second time. Went over everything with them, wanted to see if you just want to take the next step. No, I got to go. I just can't handle it. I'm hyperventilating. Left. Finally staff followed up with them. Finally, she came back today the third time, and we're starting her case in the next couple of weeks. So you have to follow up. Your staff has to learn how to follow up with the patient. It's very important.
One of the things doctors are scared about in full mouth rehabs is that when a patient spends a big amount of money, some of them have want you to warranty it or take care of it or whatever. How do you? I mean, because if I go buy an F-150 pickup truck, it's going to come with a warranty. Do you have a express written warranty, or how do you do warranty on when people are spending this kind of money?
Well, you think, look at it. Mouth is a very harsh environment. You look at a medical procedure. If none of the people in the medical world warranty anything, whether it's a heart transplant, whether it's liver transplant, something happened, it's they're going to need another one. There's a revision surgery. Then they never call it failure. The word failure is very, very, very loosely used in our profession in dentistry. I personally like to call it revision. There's times where an implant wouldn't take. Okay, we have to do a revision surgery. If a revision surgery is needed, we don't charge a patient. We just take the old implant out, put a new one in. Patient is very happy about that. In terms of written warranty, mouth is a very harsh environment. Yes, patient can spend a good amount of money and time and investment into what they're doing, but at the same time, they have to own the problem. They have to make sure that they have to follow the oral hygiene instruction, they have to follow the diet instructions, all the other instructions. My warranty or my commitment is, hey, look, if something happens, I'm going to fix it. No problem, ask. But if you're a smoker, if you're not non-compliant, you get this care done, you come back 3 years later and things are falling apart, how do I know what you're doing? So there's never any written warranty to anybody. I mean, one of their contingency is they have to come in every 6 months for their follow-up and checkup and cleaning. And there's something that can be fixed, we fix it. We give away so many services at no charge to our patients. So it has worked well. It's about direct and honest communication with the patients. And patients ask me, do I give? I said, no, I don't give a written warranty because the mouth is a very harsh environment. I mean, you have bacteria, saliva, food. I mean, a million things can happen. We can do good surgery. We can place beautiful teeth. But the other half is and I can use the best lab and I can use the best material. But the other half of this is also patients. Are they wearing the night guard? Are they compliant? Are they non-compliant? So I don't know if that answered your question.
It did. Some of the younger kids ask on Dentaltown, does all-on-4 mean all-on-3 if one of the implants fails? And what do you do if local television people are saying all-on-4, and you want to convert them? Maybe you want to do all-on-6. I mean, Brandmark did all-on-6 before Palo Malo came out and lives in Portugal did all-on-4.
Right.
What do you? So let me just start specifically. Is all-on-4 none on 3? Do you put spare tires in? Like, would you rather go 6 like Brandmark in case one of the implants fail and you don't lose the whole case? What are your thoughts on that?
That's a good question. So see, again, it's a misunderstood concept. Basically, what all-on-4 states is to do a full arch of rehabilitation. And there is peer reviews and there's scientific articles published over and over again that all you need is 4 implants throughout the upper jaw and the lower jaw, properly spread with the anterior posterior spread with proper stability to load the teeth. All you need is 4. Now, do I just do all-on-4? No, I do more than all-on-4. I've done all-on-5. I've done all-on-6. I've done all-on. I call it all-on-4 plus. If somebody needs an additional implant, I do it. It's all-on-4 is just a term. If somebody needs a 5th implant or 6th implant, absolutely we place them. But I would say majority of these cases I get, they have no bone in the back part of the jaw. They have no bone between the sinus. They only have the sinuses are completely pneumatized. So I have a very minimal amount of bone left. Then I can really place good implants with good primary stability and load a temporary prosthesis in the day of the surgery. So that I think that this whole all-on-4, none-on-3, I think it's more of a whim than anything. If you haven't done 100 plus, and if you don't have the surgical experience, then where are you getting the data? Where are you getting that information? But if somebody has full bone volume, if you can add a 5th implant or a 6th implant, by all means do it. There's nothing wrong with that, and I still do. I still place 5. I still place 6, and that's what you have to do. What's best for the patient. All-on-4 is just the minimum that you need, especially if they don't have a lot of bone. Instead of doing bone grafting, sinus lift, again, which you can avoid all that and do a good all-on-4 surgery and give them all their teeth.
Everyone listening should just check out his website, New Teeth Chicago. I mean, it's just an amazing website. Another thing that confuses the kids is they go to these courses and they hear all this stuff about the medical health history, taking a medical health history. And one of the things that really stuns them is they say, well, you don't want smokers, you don't want drinkers, you don't want all this stuff like that. Well, those are usually the people who
Mhm.
lose. I mean, the people who lose all their teeth usually aren't
Right.
yoga instructors eating tofu,
Right.
you
It's very
know?
true.
And I mean, in Phoenix, I mean, we have a joke like, anyway, I don't want to throw anybody under a bridge, but there's a section that's out in Phoenix called Apache Junction where it's known for all the meth labs and the trailer parks and all that. So a lot of these kids are like, they want to do their first implant, but this lady does everything wrong. She's 60 years old. She smokes a pack a day. She's probably an alcoholic. She probably hasn't had a vegetable unless last time she got it was at McDonald's. What do you do smokers? What do you do when people are doing everything wrong, but they want new teeth?
Sure. So a lot of our patients are what we call dental cripple. They have been away from the dental office for 10, 15, 20, 30 years. They've had a very, very fearful, very bad experience as childhood or adulthood. So they've neglected their teeth. So their teeth have really, really gone down. Either they've lost all their teeth and they're wearing dentures and they hate it, or they're about to lose their teeth because every single tooth is either perio or caries or combination of both. So, and a lot of them are smokers. So with smokers, we try to have some agreements. Look, you're investing time and money and energy into this. We go over smoke cessation. We go over prescribing medication. We talk to their physician to make sure they're going to, and a lot of them we have converted them to away from smoking, especially when they're going to change their mouth and their health. So that's a big plus. Now there are some people that do smoke, and if they're careful, look, smoking is going to cause a problem. It's only going to cause a problem with implants placement. You're going to have more bone loss. You're going to have more infection, more inflammation. A majority of our patients, like there's some patient who says, I'm not going to give up smoking. So at that point, I'm going to make a decision. If you're smoking a pack or two packs a day, do I want to take you on as a patient? And what if there are factors that didn't go right and you lose implants and you're not, and I don't want that on my hand. So there are patients that I've literally not taken and turned away because they are refused to change their lifestyle. So part of our treatment plan and protocol is to lifestyle modifications for our patients so they are healthy overall, not just getting their mouth healthy, but they eat better, they give up smoking, they a lot of them they lose weight, fitness. I mean, it's an amazing thing because we're not just fixing teeth.
So if they're smoking a pack or two a day, you won't treat them.
No, because I go through what are the consequences that could go wrong if you smoke, and there are maybe nothing might go wrong, but what if there is, and if there's something that goes wrong, then if implants fail, well then what happens? So if somebody is not willing to eliminate smoking or at least cut back, and somebody's really adamant that no, I'm not going to change still going to smoke two packs a day, then I might consider say, hey, maybe we're all better off with a denture. Maybe we're better off maybe with an implant locator. Let's try that out a little bit, see how it is. And take it from there.
When I got my fellowship in the Mission Institute,
Right.
Carl Mish and his brother Craig Mish, that was probably pretty much the main thing they didn't agree on. Carl would treat a smoker, his brother Craig wouldn't.
Oh, really?
Yeah. And you know what? I know so many patients that over the years quit smoking that were women. And I said, well, why'd you quit smoking? And she said, well, I wanted to have the eyelid surgery down, or I wanted to have a tummy tuck or breast augmentation. And the doctor said I could not smoke one cigarette 6 weeks before the surgery, or he wouldn't do it. And after they quit 6 weeks, usually after 3 or 4 days, then it's just a mental addiction. There's no physical addiction, but quitting 6 weeks so they
Right.
could get their cosmetic surgery, and now they're non-smokers.
I mean, that's great. That's incredible. I mean, a lot of our patients have gone on Chantix prior to the surgery, and they quit. I mean, it's a great thing. And they're very happy that they quit.
This is Dentistry Uncensored, so I only like to talk about things that are controversial, not what everybody already knows. Pretty much every hygienist will say that if they had to pick between um, fixed a fixed arch of implants are removable, snapping on fixed. They want the removable. They say, I want grandma or grandpa to go out and pop out that denture and brush around the implants. But when it's fixed, you need a water pick. It's tough. Periimplantitis is a big issue. Do you what do you think the size of the market is for fixed and their mental health once it fixed and it'll never come out versus converting them to where, well, if this is a denture snap on, it's a lot easier to brush and clean.
Yeah, so at the end of the day, patients want teeth, Howard. Patients want teeth, and majority of the patients want teeth that stay in their mouths. So, yes, from a hygiene perspective, I can agree that when you take the snap-on overdentures out, you can clean the locators or clean the bar and put them back in, and that works for a good amount of patients. There are some patients who want teeth that don't come out. They don't want to take them out. So from a hygiene perspective, yeah, people can use water pick, people can use hygiene aids, and when they come in for their recare, we take them out. We take the teeth out. We take the teeth out. We clean the abutments. We change the prosthetic screws. It's part of our service that we give them at the when they come in for the 6 months. So cleaning them is really not an issue as long as the patient is able. And if you design the prostheses that are self-cleansable, you're not going to have a lot of these patients when they come in. When we take their hybrids out, you find very little plaque, if any. So and it's all about educating the patients on how to clean them.
Everybody's talking about periimplantitis. How significant is periimplantitis? What are you doing to treat it? What's your views on periimplantitis?
So the periimplantitis can happen for even a single tooth implant or full arch. The most important part is how well are they maintaining their plaque. The kind of implants that you use, if they have better collars, better surfaces, like laser lock, it's so nice that you get nice soft tissue growth around the implants. The abutments are so nice and polished; it doesn't build up a lot of plaque. Even people that accumulate a lot of plaque. So you can have periimplant. I've had some cases where there's some bone loss around the implant, especially in anterior patients not cleaning them. A lot of times you can just clean out the defects, bone graft it, put the bone back in there, and the implant doesn't have to be removed. And so I don't see a lot of periimplantitis. A lot that can happen either from whether you're doing the surgical and the prosthetic part properly, proper oral hygiene, using the proper it's all about the design, the prosthetic design. It's about the end result. If you Are you doing platform switching? Are you using what kind of implants are you using for what case? And also, what is you and your team are doing about the hygiene and educating the patients about hygiene. So we don't get a lot of periimplantitis in our office.
You just walked into a wall when you said platform switching, because I know there's a lot of homies listening who don't know what that means. Explain what you meant by platform switching.
What I meant by platform switching is if you're putting a wide diameter implant, say a regular diameter implant in the front, but you need to have the prosthetic. Prosthetic is what the patient sees. Prosthetic is the tooth, the abutment of the tooth. So a lot of implant companies will have an implant that you can switch to a narrower diameter abutment fixture. For example, if you're putting an implant on number 7 through 10 or 7 and 10, you put a regular diameter, but now you want to make sure that there's enough adequate tissue height, there's enough soft tissue, and if you put a wide platform, abutment and a crown, you might not have proper soft tissue aesthetics. So some of these implant companies have platform switching, where you can switch to a lower platform prosthetic connection to have the better prosthetic outcome and aesthetic outcome as well.
You've been so amazing by giving me so much time. What would you tell a kid who's stressing out? They're starting with single implants, and they're going to do their first. They see a patient that needs a sinus lift and implant. What advice would you tell them on sinus lifts? There's all kinds of sinus lift procedures.
Absolutely.
What would you tell about sinus lifts?
I would learn to go to either there's a clinician who has done quite a few, a specialist who's done quite a few, or an implantologist who've done quite a few. Learn from them. Go to their office, see one, look at the armamentarium used. Look at how they do the flap design. Look how they do the oval window. Look at it. Just don't go to a weekend course in sinus lift and come back and lifting sinuses and placing implants and membranes. I would say go to a experienced clinician and just shadow them or learn from them a little bit, and then take on there. Maybe bring your patients to their office, maybe for a first case or two, just to kind of work together. That's what I would do.
Podcast with Carl Mish. He thought that drawing blood and spitting blood was not necessary, and that created a big controversy. What do you draw blood? Do you spin blood? Is that part of your regular protocol?
I've done both ways. I've used to do lots of PRP, which is taking out blood from the patient's hand, spinning it, and using the PRP for proper soft tissue regeneration, angiogenesis, and better healing. It worked both ways, Howard. I mean, is it ultimately necessary? You have to look at your cases. I've done so many cases without it. Now everything is about PRF. Everybody wants to do PRF. Now I have cases where there's very deficient bone. We're going to do simultaneous bone grafting and implant placement. Somebody that is a little bit old and frail, vascularity is an issue. Absolutely. Drawing out blood using some PRP and PRF is going to be a great adjunct. It'll heal really well. Why not? Somebody that's young, somebody has a very vascular, they're losing their teeth, but they're healthy. I really don't think it's necessary. So it's dependent upon cases. Case selection is everything.
So you're saying on a 55-year-old young grandpa like me, you wouldn't do it?
If you're healthy, your bone is vascular. No, I probably won't. But if you have lost a lot.
My job is to predict what my homies are thinking. They're all alone. They're driving to work. This is a commute thing or an hour on a treadmill. You said PRP, PRF, and someone's out there saying, what's the difference? What is that?
The only difference is the PRP is platelet-rich plasma, so you're only restricted to using the platelet-rich and platelet-poor, and you're sometimes a lot of times we just put in the implant, coat the implant with it, place the implant, put it inside osteotomies, and have regenerate, have angiogenesis, soft tissue healing. PRF, this is what it's going towards. A lot of people are giving courses. It's actually clot. It's platelet-rich fibrin and sticky bone. That's what they're using, and it really helps with a lot of soft tissue regeneration. It helps with a lot of getting that really nice keratinized tissue around your implants, especially when you're doing a full rehab. When you have a very, very narrow and resorbed maxilla or mandible, there's very little thin biotype. You want to grow a little bit of that. You use a little PRF with some membrane, and when you close everything up, you get a really nice attached gingiva soft tissue. I mean, that's the difference between the two.
I can't believe we've already gone 1 hour, but I have to ask you one last very controversial question.
Sure. Okay.
A lot of these kids come out and they get an associate they're working for an older man who's 55 to 70. Every 55-year-old to 75-year-old dentist who's placed 1,000 implants never used a surgical guide one time in their life. And these young kids say, well, I want to make a surgical guide. And he says, well, why don't you go home and put training wheels on your bicycle? And you need to learn how to lay a flap and blah, blah. So the old guys, no surgical guides. The young guys, they read about it all the time. What's your view of surgical guides? What % of your cases are you using a surgical guide?
I would say, Howard, I don't use a lot of surgical guides.
See what I mean?
I don't.
Yeah, the guy who did 1,000 arches, of course. I mean, I saw that coming.
I don't use a lot of surgical guide. I like to flap. I like to see the bone. I like to, and I just came from a BioHorizon symposium in Miami last month, and we can do it both ways. Ultimately, what is your result? A result is patients want to have nice teeth. Okay. When I've done guided cases, when the patients are fully edentulous. It's a lot easier. It's more predictable. A lot of my cases, the teeth have to be removed. You have to do bone reduction. Then you have to place the implants. You can do that now. Now you have end-sequence. You might have heard of end-sequence technology has really come up with a great way for people that want to employ surgical guides, bone reduction guides, surgical guides, especially with these full arch cases. So you can do that. I still like to reflect the flap. I like to see the bone. I like to feel the bone. And that's just me. No right, no wrong. There's a lot of group discussions on Facebook and this, and guided surgery is the best way to do it. I wouldn't say it's the best way to do it. Sure, it could be, but there's so many times where if the guide is not placed properly, how do you know where the implant is going if you don't have a flap? At least I can see the bone. I can see the dehiscence. I can see the fenestration. I can make changes to my implant. If my implant doesn't go all the way I want, and my abutment is too facial, well, I can turn my implant quarter turn and rotate my abutment. Now, that's just me. That's just how I like to see it. Somebody right out of school may want to just do all cases guided, and there's nothing wrong with that. But I personally would say before you do, especially full arch guided cases, do 100 of freehanded. You got to learn how to cut. You got to learn how to flap. You got to learn how to feel the bone. You have to do it conventionally. Then you can take on some guided cases. But jumping into guided cases, it's like, why are you afraid to pick up a scalp and reflect? I mean, I don't understand why would not somebody want to do that? If you're learning a skill, you're learning a skill, why wouldn't you want to learn it? Then you can employ the guided case. So there's both ways you can do it.
Last question. I promise to let you go. Someone might be wondering, what CBCT do you use?
I use the ICAT.
The ICAT.
I use the ICAT 3, yeah.
And do you, when you're at a DI, a Diplomat International Congress on Pathology course, does it seem to you that that is the leader among all the people who placed 1,000 implants?
I mean, the diplomat is the highest distinction in the ICOI. There's also board certification through ABOI. I'm working on that right now. And if you get the beyond the fellowship and masterships and diplomates, I mean, diplomate's the highest distinction. But again, materials change, protocols change, different methodology change. I'm always trying to learn something better way of delivering my surgeries and also my prosthetics every single time, every single day. So even though you become a diplomat, the learning never stops. I make sure I keep on learning more and more and more, whether it's through articles, whether it's through symposium, whether it's through even traveling abroad, wherever it is. It just doesn't stop.
I hope someday you honor us with an article in Dentaltown magazine or an online CE course, because I can't think of a finer person these young kids should learn from than you.
Thank you, sir. I'd be glad to. It would be my pleasure. We would definitely coordinate that very soon, and I would love to. I've done one article. You and I talked about it back in 2010, but I would love to do another one. I have a lot of content that I can share with the audience.
Well, thank you so much for all that you do for your patients and for dentistry.
Thank you very much. Thank you for having me.